be the lone person looking after patients. They will bear responsibility for every decision. They will talk to the patient, and that inadequacy of healthcare system is quite evident for centuries, because it's only one person, the face of health service, which is the physician or the doctor. But now we are at the transition that we are making decisions which are team based. So I hope we can see something on the screen now. So I changed my talk that we are transition from team based to surgical practice, and MDT is one of the examples of that. So in my talk, I'm going to talk about traditional practices, what we do now, what's the future, and what are the suggestions for change. Now, has anybody seen this painting? This is a very famous painting called The Physician. It's in Tate Museum in London. This was painted in 18th century by an artist called Luke, who was a doctor himself. So what do you see here? And in the interest of time, I'll take you through what we see here. So there's a child who's dying. Parents are in the background. Distraught mother, father, looking at the physician, who's looking at this patient and can't do anything. So what does this painting tells us? Parents are looking towards the physician to do something miracle or magical about this dying child. But this also shows the inadequacy of medical profession, that we can't do everything. But he bears the burden of all the decisions which this person is going to make for this child, which is a huge responsibility. Now the practice of individual physician has been the topic of comedy in Britain and US comedy. And I'm going to show a clip which is called Doctor in the House, which will show you it's a comedy, but the traditional surgeon, how it used to be in the British healthcare system. That's a surgeon coming. It's a very heavy British comedy. Doctors waiting. Not following the dress code. No privacy. Right. So this was a traditional surgeon in Britain, and I think in our healthcare system we still see some of these traditional surgeons. Person with no complete hierarchy on top of the tree, thinks he knows everything, and there's no respect for patient privacy. So lots of things which we see are wrong here, but we are moving now. But remember, although this person looks the most powerful person, but is still alone. So this person is still alone, getting the burnt of all the decisions that this person is making. So there are limitations and challenges, but we have moved on now. This is in UK, where we do the ward rounds outside the wards, where everybody sits around and make decision about the patient. But there is a problem. Who's missing here? The patient. So patient is not here. So MDTs happen when all the teams sit together and they decide about future of the patient or future management of the patient. So everybody's sitting here. And this is our MDT just yesterday, and I've just taken a picture of this. This is MDT in PKLI where I'm working. So the core members are sitting here, pathologist, we are discussing the scans, and the supporting team sitting in the background. So everybody is sitting in a single room making decision about the patient management. So what's the benefit of this? First of all, it improves patient outcome because the diseases are becoming complex, management is becoming complex, and shared decision making because we don't know everything. As a surgeon, I don't know everything. Now this is just an example. Don't go through this slide. This is HCC, one of the very common cancers in surgery. And look down here. What are the management options? And how many specialties they require to make these options? Ablation, resection, transplant. This is ablation during resection, TACE, sorafenib, BSC. So just to make these decisions, you need an intervention radiologist, a surgeon, a transplant team, again, a surgeon who can do ablation in theater, intervention radiologist, oncologist, and palliative care. And to support this decision, you need radiologist, pathologist, and then you need coordinator. So just for one disease, you need so many people, and one patient cannot go to all of them individually to get that decision. So teams have to come together to make that decision together. So that's why MDT concept has come in. But the problem in MDT team is there are lots of people sitting together. So if you don't make proper communication channel and leadership responsibilities, then things will not be executed. Now, what do you do? First of all, why MDT team is there? MDT team is there to make decisions about complex disease process where there is more than one specialty involved. What forms MDT team? There is no definite composition because MDT teams can be for transplant, complex specialty, cancer, complex specialty, but it's also for non-cancer. And I'll give you an example. We used to have MDT team for pancreatitis. So acute and chronic pancreatitis. And how many specialties you need for chronic pancreatitis? Physician, surgeon, pain specialist, endoscopist, a diabetologist, endocrinologist, and these patients are in UK are either alcoholic or chronic smokers. You need those support teams. So even for non-cancer, you need MDT teams coming together. So in the setup, and I'm using this as an example for team building, you need to see what's the frequency of MDT meeting should be. In PKLI, we get 2 MDTs for transplant every week, and we discuss about 30 patients. And it's a 2-hour meeting. So very heavy load. But for example, if there's MDT team for neuroendocrine tumor, which is not a common tumor, you might need it once a month. So you have to decide it according to the need of your system. So case discussion and decision making process, very important. Because if I go to MDT meeting, I've not seen the patient if somebody else is bringing those patients in. So it's very important for the team to give very clear history so that I've got a picture in my mind what that patient looks like. What are the comorbidities of the patient and how fit the patient is, because we are going to make that decision based on that. Now, the team will make a decision. There should be clear documentation of it, and we document on the screen in front of everybody so that there is no ambiguity and everybody can see it. Now, implementation is interesting. Remember, MDT team is not a legal binding. It's a guideline, because teams will make a decision, but responsible clinician will make the final decision. So MDT team is just a guideline. And it's important to keep on getting feedback and keep on getting the audit. So I use this diagram. It's an interesting diagram how we change. So if you look here, we know what the problem is, complexity of the disease. Idea is to change it. So idea is to change it. How? We have talked about it. You need systems, but then you move from me, it to we. And it's a combined decision making of the team. And that's where teams share responsibility of any decision which is made for the patient. So you move from me, it, and we, and then you create a leadership of that MDT. There should be a clear leadership, clear communication channel, and clear execution. So, but there's a problem, but there's always problem. Resistance to change. We don't want to change as surgeons. We think we know it all. We think, and I still get patients coming from all over the country where surgeon has made decisions about oncology, about medicine, about everything. So we can't take responsibility of everything. I know how to operate, but I don't know how to give chemotherapy. But so it should be we, but then there's resistance to change, and I think this change will happen in the next few years. Time constraint. You're getting so many people out of their valuable time into one room sitting together. So the leadership of the hospital will think that is a wasted time. But I think that is important. And other thing is communication and documentation. I believe in Shalimar you have got EMR, electronic medical records, and that makes problem easy. But most of the hospitals have got paper-based records, and that can be a problem. So it's going to be education and training, leadership support, and continuous quality development to see whether it's making a difference or not. So because of time, I'm going to move further. So the most important thing in MDT is real-time data collection, because MDT generates a lot of data. You know what your volume of the patient is, what the decision has been made, and what the outcome is. So that decision making becomes very, very important, real-time data collection. I showed you the picture there. Patient was missing from the initial picture. So it's very important to involve patient in that care, because our job is because of the patient. If you take patient out, there won't be any healthcare system if the patient is not there. So patient is the most important person in our healthcare system. So all these processes will need constant development and constant valuation. And it's important. But you're forming from individual, you're forming a team, and then you're checking the progress of the team. And this is only important if you constantly keep on taking feedback from the members. So we take feedback every month to see how effective MDT is, are patients coming in at the right time, what is the decision, how the decision is documented, and keep on improving the process. And I think in your practices, in young generation practice, you will see MDT being incorporated in your routine practices wherever you go. Now, this thing is about AI and future. I'm going to talk about AI and future of technology in my next talk. But remember, lots of things are going to come in. AI, robotics, and new techniques. So you will see other members who are not healthcare professionals coming to your MDT meetings. So MDT meeting is not only of healthcare professionals, but allied healthcare professionals coming in. Now, this is a very interesting video which I normally show. This is about team building. So when you make team, now whenever you make team, it's important to make a functional team. Person wants to start a process. So he's a performer. So that's somebody who's pushing the process. So, and you will see lots of performers in the team trying to do it alone, but you want a team around you. Somebody else has joined in who are doer, wants to do it. for not doing it effectively. But he's trying to do it. And if you are mentoring this doer, this will become performer one day. But then you get other members of the team, again a doer, but doesn't do it very well. Willing to help, but not a lot. But then there can be problems in the team. This is a trouble source. Sometimes it helps, sometimes resist, helps. And then you get potential troublemakers in the team. So remember, never get the team which has got potential team makers. So the person who is performing has got lots of problems. So this is an effective team where everybody is moving in the same direction. And that's why it's so important to form the right team. And if you don't have the right team, sort it out. Because if you don't sort it out, you will have problem throughout your career. Right? So I'm going to end up here. Again, we talked about the team, and this is just a song. And I think Dr. Talat might remember this, because last time you asked me to come and do a talk, I put it here. Bob Dylan is a Nobel Prize winner songwriter. So he wrote lots of songs about things which change. And again, this is a beautiful song, and I'm not going to read all of it, but times they are changing. So for you guys, times are changing from individual to team-based practice. And I think that's quite important to think about it. So a flat hierarchy, team-based practice, and that is how you're going to be trained in future. Because of time, I'm going to yield to Dr. Irfan Kabir, who's just come in. Thank you very much, and thank you very much for listening.